quick video of microsurgical management of giant olfactory groove meningioma. This 45 lady presented with worsening headaches of 3 months, progressive right side weakness, and 3 episodes of seizures. Examination showed she was dull, withdrawn, expressive dysphagia, right hemiparesis 3 by 5. With this, she was investigated with CT scan brain, contrast MRI scan brain, MRI DTI images, MRI angiography showed large left frontal basal meningioma with significant edema and mass effect midline shift as shown in these images with the significant pressure. The meningioma was extending from the base, going superiorly, posteriorly, and laterally, more on the left side, not crossing the midline. MR showed widening of anterior subluxary, middle subluxary complexes and the lateral displacement of middle cerebral artery and posterior displacement of anterior subluxary and elevation. DTI images showed the widening of the long association fibers and posterior displacement of corticospinal tracts as shown in these DTI images. With this, she was taken up for surgery, underwent in supine position, bicoronal scalp flap, left large frontal temporal basal craniotomy, transbasal approach. These are the scalp flaps behind the hairline to avoid the scar. The left frontal temporal basal craniotomy was done based on pterion going up to the base of the frontal region up to the orbital ridge. The dura mater is open, the base towards the midline, and now you can see we are right on the base of the anterior cranial fossa. And as soon as gently to elevate the frontal lobe, which is swollen and edematous and under pressure. The tumor is encountered at the depth of about 1 to 1.5 centimeters from the surface. The most important step is here to rapidly debulk the tumor because tumor with the brain is already under significant pressure. One needs to create a space and reduce the pressure on the brainstem. Rapidly, the basal part of the tumor from the anterior skull base is debulked all around, at the same time maintaining the hemostasis and keeping the operating area clean. The tumor here appears to be very vascular and has blood supply probably coming from the middle meningeal branches, basal branches of the dura mater, and coming from the anterior cerebral artery and maybe the middle cerebral artery cortical branches. As you keep going debulking, keep achieving the hemostasis as shown here at every step. Keep the area clean. Now we are going through the base and you can see the blood supply coming from the base going into the tumor, which is coagulated medially. Blood supply from the medial aspect, it is coming from the anterior cerebral artery and the falcine vessels. They are coagulated. That's the medial end of the tumor, probably originating from the olfactory groove. The olfactory nerve is not seen here. The tumor is very large and it's very difficult to delineate the olfactory nerve. Tumor is taken for biopsy and tumor appears to be soft and necrotic but highly vascular. You can see the amount of bleeding continuously. So here we need to be very fast and keep debulking the tumor. These tumors, they don't stop bleeding unless you take off completely, unless to devascularize them from the base as well as from the cortical vessels where they get the blood supply from. So now we are debulking the medial part of the tumor, medial and superior part, along with the fox, and the tumor is being debulked and the blood vessels, you can see dilated large vessels inside the tumor which are bleeding. They are coagulated. That is the basal part of the tumor, probably originating from the cristagalli and midline. The tumor is more vascular here, as you see, and keep devascularizing, debulking. You can see the blood supply there, the vessels going into the tumor there, which are coming into suction. These are the branches of probably the falcine arteries and cortical branches of the anterior cerebral and middle cerebral arteries, which are supplying the tumor. So coagulating these and reducing the blood loss is of utmost importance at every stage. And we need to be very fast in debulking and coagulating these lesions so that the blood loss is reduced and the operating area is kept clean. Always remain in the plane of cleavage inside the tumor. Don't cross the capsule or the periphery of the tumor, because in soft tumors like this, it is very difficult to assess where the tumor stops and the brain parenchyma stops. So keep looking for the abnormal tissue and keep debulking. Now we are debulking the superior and deeper part of the tumor and lateral part of the tumor. Now that is the superior and medial part of the tumor which is being taken out, and you can see the amount of bleeding taking place in the tumor bed. So the hemostasis is achieved. Now, as I mentioned to you earlier, almost the whole tumor is debulked superiorly, medially, laterally, and inferiorly. That is the deeper most part of the tumor. As you go deeper and the basal part, we need to keep a watch on very important neurovascular structures like optic nerves, optic chiasm, and anterior circle of Willis, both the internal carotid arteries, anterior cerebral arteries, middle cerebral artery, and anterior communicating artery. This is very important to keep in mind, because very easily we can miss this and go into those structures. So keeping a watch is of utmost importance. As I mentioned to you earlier, once you take off the tumor completely, automatically the bleeding comes down or bleeding stops. Now you can see the bleeding has come down significantly, and the deeper vessels which are supplying the tumor are being coagulated, and you can see the basal frontal part of the tumor, from where the tumor is originating from the anterior skull base, medially around the olfactory groove, crista galli, and clearly from plate of the ethmoid bone is being dissected. That's a major part of the tumor. You can see the origin there, significantly adherent. Dura mater is taken out to achieve Simpson's type 1 excision. That is the tumor where the crista galli and cribriform plate of ethmoid bone are located, and you can see the midline of Fox there, and the tumor origin it's coagulated. Since it is unilateral on the left side and in such a large lesion, difficult to separate the olfactory nerve. You can sacrifice the olfactory nerve on one side. Already there is a right side. The tumor is not extending and it's not going across the midline. The olfactory nerve is preserved on the right side. That is the Fox, basal Fox origin from the crista galli. That is the part of the tumor in the cribriform plate of the ethmoid bone is coagulated and taken out completely from the base. Now you can see that is the basal part of the tumor. The blood supply is quite extensive from the dura mater as well as the bone. Probably gets the blood supply from anterior and posterior ethmoidal arteries of the ophthalmic division of the internal carotid artery. They are coagulated, and basal dural branches of the middle meningeal artery are coagulated, and the hemostasis is achieved completely, and the dura mater is taken out completely to achieve Simpson's type 1 excision. Now that is the basal part taken out completely, and as you do that, now you can see posteriorly. I was mentioning to you earlier, you have to keep a watch posteriorly and inferiorly on the important suprasellar neurovascular structures, and they are optic nerves, optic chiasm, and carotid artery, and the anterior circle of Willis. That's the deepest part of the tumor superiorly, which is coming out into the suction and taken out completely, and that is the basal frontal region, superior basal frontal region. There's some bleeding from the gliotic frontal lobe medially, which is coagulated and the bleeding stops. Now you see there is practically no bleeding because tumor is taken out completely, remaining in the gliotic vein. Now you can see once you take off the blood collected there gently with the suction, the suction should be very gentle, not to catch up any of the perforators and the anterior cerebral artery and middle cerebral artery and interleukotid artery. Thereby, if the suction is strong, we can push them to develop vasospasm due to mechanical injury. Now you can see both the optic nerves there. That's an optic nerve on the right side, optic nerve on the left side. You can see the anterior cerebral artery on the right side. You can see coming down here. Here the anterior cerebral artery on the right side appears to be quite smaller or hypoplastic. Now you can see the optic chiasm there and both the optic nerves, right and left. Now you can see the left interleukotid artery and bifurcation into A1 and M1, and we can see the medial lenticulostriates, that's medial lenticulostriates, recurrent artery of Hübner's, and laterally from M1, lateral lenticulostriates. We keep washing the area with the piperine saline all the time to prevent postoperative vasospasm due to surgical handling and the mechanical suction and bipolar use. That is the tumor origin from the base is extensively coagulated to prevent the recurrence, and the dura mater along the base is taken out to achieve Simpson's type 1. That is an olfactory nerve originating from there. Here one needs to be very careful because sometimes these tumors erode the skull base, go into ethmoid sinuses, and you have to see that there is no bony erosion. If there is a bony erosion, we need to reconstruct to prevent CSF rhinorrhea postoperatively. Now you can see the suprasellar microsurgical anatomy. On the left side, interleukotid artery, optic nerve, bifurcation, A1 and M1, lenticulostriates, anterior communicating artery, and right side you can see anterior cerebral artery and the right optic nerve, and in between the two optic nerves you can see the pituitary stalk there, interoptic space. The hemostasis is achieved at every stage. There is a small bleeding from the perforators who should not coagulate. Just pack them with Surgicel, pressurize, they stop bleeding. That's the end stage of surgery. You can see that the bleeding, absolute hemostasis is achieved. Ask the anesthetist to increase the blood pressure by 30 to 40 millimeters of mercury compared to induction level, and confirm the hemostasis because the tumor area is quite large, raw area is quite large. There should not be postoperative bleeding. Wait for 15 to 20 minutes, confirm there is no bleeding. Dura mater is closed, watertight as much as possible with the pericranial graft. Bone is replaced and fixed. Same day evening, CT scan shows complete excision of the lesion, no hemorrhage, no edema, no infarction, ventricles are normal, tumor taken out completely. This is her post-operative clinical status on day 2, glaucoma score 15, no deficits. Preoperatively, she was dull, withdrawn, drowsy. Now she is fully alert, obeying all the commands. Operatively, due to her poor neurological status, we could not assess her vision. Now she appears to be quite normal. Her vision on both the eyes is quite normal. This is her post-operative clinical status on day 6, the day she goes home. Wound has healed well and there are no deficits, is independent, ambulant. The right hemiparesis has recovered completely. The histology confirming atypical meningioma grade 2. We need to wait and watch. Our neuroanesthesia team, treating physician, neuro rehab team, our presence online with more than 635 microsurgical, endoscopic, exoscopic, navigation guided, educative neurosurgical operative procedural videos on our YouTube Neurosurgical Video Atlas. Thank you very much for viewing.